All right, guys, we're dropping here into the podcast, and I want to ask Stefan a big question, and because we're going to be talking about a more of a holistic approach to medications for mental health, and maybe getting off a lot of these, what him and I talked about this morning, the mood stabilizers, right? And all this medication that we're just seeing people on time after time after time. And he has a psych protocol, which if you're watching this video, he's standing right next to you right now, and we're going to get the whole visual while he's talking us through this on the podcast. But I'd really like to start with asking Stefan first, like, what was it that made you want to make this protocol in the first place?
Well, I worked in psychiatry for about 6 months as a PA, and I saw a lot of patients remotely via telemedicine, and I approached them as I normally would. And I approached them with a functional medicine root cause approach while I was working in a conventional model. And this wasn't always appreciated by my staff, by my supervisors. I actually got in trouble for this same protocol. One patient called me out on it. He sent a screenshot of my protocol on FullScript that I had suggested he try for his symptoms, and I got in big trouble for that. And as part of why they had me leave that facility, among other things. But I was getting patients off their psychiatric medications by getting them to exercise, change their diet, and take the right nutrients that they were deficient in. And this is a no-go in conventional psychiatry because it's not considered FDA approved. It's not considered standard of care practice. The standard of care practice is you get a diagnosis and you find the right drug for that diagnosis, and that's the end of the story.
Right. And I'm noticing on your whiteboard next to you, you have 15 different things listed out. And the question comes to mind, are these going to be things that are for specific disorders, like mental health disorders such as bipolar, depression, anxiety, or are these things that you're going to be talking about more for a generalized mental health approach that maybe can be generalized that help you overall, not just one specific disorder?
Yeah, so these are going to help the whole body. So we have to separate ourselves from the allopathic approach to diseases. The allopathic approach is based off the petropharmaceutical model. Is what I was trained in as a conventionally trained PA. It was to identify the diagnosis. So in psychiatry, this would be using the DSM-5 criteria to find a diagnosis. Once you have this diagnosis, say it's depression, you can then use that diagnosis to prescribe approved drugs for that disease process. But as many in allopathic medicine will know, if they've worked for an extended period of time, is that patients with depression often have anxiety. They oftentimes also have ADHD. They probably also have diabetes and a couple other common denominators. So even in the allopathic model, we know that there's a bunch of problems. There's a syndrome of or a constellation of issues. So, if we want to try to get one diagnosis for one drug, that's the wrong way to approach it. We want to treat the whole body to get all the biochemistry working right again. And it takes both you have to get sunlight, you have to exercise, you have to eat the right diet, you have to take the right supplements, you have to make sure all the hormones are optimized. This isn't going to treat one disease. This isn't going to just treat depression. It's going to make your energy improve. So that would treat chronic fatigue. It's going to improve your pain. So that's chronic pain. It's going to, improve your cardiovascular risk. So that's cardiovascular. So we're treating a spectrum of diseases across multiple specialties with this approach. And that's what people need to understand. It's not one disease.
I love that we're going into this because all I can think of is in my head, like you said, people have anxiety, but then they also have depression and they have ADHD. We never just see one thing. And another diagnosis that comes to mind that I see this often with is PTSD, right? Where they come in with that diagnosis and then it's like, oh, but they have anxiety and they have depression and maybe they have panic disorder. But a lot of practitioners know these are all part of PTSD. Why are we diagnosing and putting labels on every single part? It just hasn't made sense to me where nobody is really getting the whole body approach because it's very rare that you even see practitioners say like you should focus on your diet, exercise, and sleep. And that's one thing that I always bring up to clients. And I love that you go there too, but it's just nobody wants to put their hands in all of these cookie jars. They just want to treat that one label. They're like, that's the one responsibility I have. And that's it. So I love that you're bringing up this list, and I do want to give you time to start explaining it.
Yeah, I mean, if you just Google search the correlation between diabetes and depression, it's right there. you know. So that's well known, that's well established, but they're two separate diseases. One goes to an endocrinologist, one goes to a psychiatrist. But here, me and Ciara, we know we treat them both. Exercise, that means cardio, hit training, weightlifting, sunlight, proper diet. We've talked about that in other podcasts. But today I want to go through kind of my list. Say we've optimized the diet. We're doing strength training. We're still not feeling great. What are the next things to do? Well, you want to come to a functional medicine, and we would assess some of these things. I put lithium orotate at the top of the list because this is people may heard of lithium. They know that it is actually a psych drug. They prescribe it, but it's not orotate. It's lithium carbonate. Lithium carbonate is different. It's actually kind of toxic and it gives people terrible side effects, but it's used in psychiatry for bipolar depression or treatment-resistant depression.
Yeah.
It's a pretty toxic drug, though. Not a lot of people tolerate it. Lithium orotate is a natural mineral found in spring water. There is a crazy study out of Texas where they found that there is lithium orotate in the well water, and this whole city had less homicides, suicides, depression, anxiety. Everyone was much happier because they were getting lithium orotate, which is found in mountain valleys and in Japan, in Switzerland. But we don't get this really into the diet. It's not in people's diet. We don't drink mountain spring water from Japan. So you can take lithium orotate, 10 to 20 milligrams, and helps people's mood. They feel better, anxiety, depression. You might notice some surprising things just with like one item, one mineral. So that's just one. The other one, probably number two most important on the list, would be vitamin D, D3K2. This is well established that people with low vitamin D have more depression, more diabetes, more anxiety, more cardiovascular disease, bone fractures. So across the spectrum of diseases, and everyone's vitamin D deficient, especially in your part of the world at this time of year.
Right, and this is something else that comes to mind. I've seen vitamin D offered without K2 on the bottles. Is this something that people should be aware of and that they should specifically look for in vitamin D?
Yeah, you should. You should never take vitamin D alone.
Okay.
The problem is because vitamin D alone will increase your calcium concentration. Increasing calcium concentration in the blood potentially can be cardiotoxic. You can get calcium plaquing in the arteries. K2 makes sure calcium goes to the bones, make sure your bones are mineralized correctly.
And just kind of looking at your whiteboard right now, for that lithium orotate, it looks like 10 milligrams. Is that, am I reading that right? I just want to make sure. So
10 to 20 milligrams.
10 to 20 milligrams.
We'll put a link in the description afterwards and people can order this protocol. But 10 to 20 milligrams is where I find people's mood improves dramatically.
Wow,
number three
vitamin D
is
too. Cool.
You get yourself a solid multivitamin. The multivitamin is going to have some vitamin A in there. It's going to have vitamin D, and it's going to have a B complex to cover a lot of the B vitamin deficiencies that contribute to anxiety, like B12 deficiency, B6 deficiency. If you're drinking alcohol, if you're eating a poor diet, you're not going to have B12. It's going to be depleted in your diet. And especially if you're taking some pharmaceutical drugs like metformin, this depletes certain B vitamins as well. A lot of people are B vitamin deficient. It's a very low-hanging fruit to take a multivitamin with some B vitamins. But you also want to make sure it has selenium in there. And I see a lot of products, they're underdosed on selenium. You want to have at least 200 micrograms. And I often suggest taking it twice daily. And the reason is because B vitamins are water soluble. So they're in and out of your body over the course of the day. So you dose it twice so you have a consistent dose of it. That's compared to fat soluble like vitamin D or vitamin A. These are fat soluble vitamins. And so once you have a therapeutic threshold, which for us, we look at vitamin D 25 hydroxy in the blood, and we shoot for about 70 to 100 in the blood markers. And I'd say most people are way under that. And especially where you live, you're probably have people around 30s and below on vitamin D if you tested them.
Oh, big time. And something that I've learned too from moving from Florida to Utah and being chronically low in vitamin D, because you don't get a lot of sunlight, especially here in the wintertime, is that your bones ache. And I'm not talking about just like, oh, it's a bone chilling cold, but my bones ache and it would be hard to even move and walk up and down the stairs. But once I started taking vitamin D, that went away. Working out got easier. It's really interesting.
Oof, that's bad. But yeah, we take selenium because it's very important for thyroid function. And so I also have iodine on this list, iodoral, about 12 milligrams. And this may seem like a high dose for some, but This is well tolerated. We've given this 1,000 of patients at the practice. So long as you give them selenium, that buffers the the oxidation that iodine can sometimes cause. Of course, you can get the lab markers tested, thyroid peroxidase, thyroid globulin. Of course, you can monitor these. But we're publishing a study actually here at the practice. We've tested about 150 patients. We've tested random urine iodine. We've tested serum iodine, and we've tested them with the iodine challenge testing. And approximately 80 to 90% of these patients are iodine deficient, even by WHO criteria. So this is severe iodine deficiency. This isn't something that's happening in a far off place like Afghanistan or Africa, like we were told. No, iodine deficiency is here.
Right. And like, what causes iodine deficiency? Like, is it just our diets? Because I know for a fact, like, it is hard to come up with foods that have iodine in them.
Right.
Couldn't tell you.
It was they in the 1900s they put iodine in the salt because it was a problem. People were getting large thyroids, they were getting goiters, low IQ in children, developmental disorders, behavioral. That sounds like what we're dealing with now. That's all iodine deficiency. So, and then we're here in a coastal area, right on the beach. You think people would get enough iodine from seafood? No one's eaten enough seafood to get enough iodine. So I think that's why we're seeing iodine deficiency. This is not in the diet. It's gone. And everyone has low thyroid function, chronic pain, behavioral disorders, mental health issues. They're nutrient deficient, especially with iodine.
Right. And again, like, I knew iodine was in salt, but what's the first thing people tell you to cut back on? Salt.
Salt, yeah. But if you get sea salt, it actually isn't iodinated.
Yeah, that makes sense.
Yeah.
Okay. Wow. The more you know.
So magnesium threonate, there's several different forms of magnesium, approximately about 7. I use threonate because it's one of the few that actually crosses into the brain and can cause a calming effect for someone. So we'll give this to people with anxiety. They can take it a couple times a day. Or maybe if someone has racing thoughts at night, they can't shut off the brain, take some mag threonate. You will chill out. You'll feel a lot better. Plus, most people are magnesium deficient anyway, so this will improve your cardiovascular disease risk. You won't get as many muscle cramps. Your muscles won't be twitching. Restless leg syndrome might improve. So magnesium is a miracle.
Does magnesium have to be accompanied by something?
Well, vitamin A typically is suggested, so that would be covered in your a little bit of vitamin A. But it might not be enough. Unless you're eating beef liver. Beef liver has high vitamin A. Some vitamin D products might be combined with vitamin A, but you're right. People may be deficient in vitamin A as well. And vitamin A deficiency is actually what precipitates measles. So in Africa, they deal with a lot more measles outbreaks than we do. Is from vitamin A deficiency. It's because they're very poor. They eat a lot of grains. They don't eat a lot of meat. So they have vitamin A deficiency. So they get a lot more measles there. But measles is actually the old treatment for that was vitamin A, high doses, approximately like 200,000 units in the ICU for children. It was done safely. But I measure vitamin A in the blood, and most people are deficient in vitamin A.
Yeah, I believe that too, especially if we're going with no meat. I can imagine.
No meat. Yeah, or vegans.
Yeah, vegans. I'm just thinking of that. I can't believe it's not meat, or I can't think of what is it? The Beyond Meat, that stuff that they substitute for.
Let's see. Oh, fish oil, omega-3. So there's actually been a lot of studies on fish oil in depression, and you can find the studies on that. It's great. So most people are deficient in omega-3s. They're eating way too much Chick-fil-A, Panda Express, getting too much omega-6 into the diet. And if you test people's omega-3 to 6 ratio, as we do, it's so bad. The 6 is like way off the charts, and they have like no omega-3s. It's very important for your brain. It's good for developing children. So pregnant women interested in getting, pregnant, having children with high IQs, you want to make sure they're taking omega-3s and iodine. This will increase the IQ of the children. This has been demonstrated. But it works for depression too.
Wow, make smart kids. Omega-3 and iodine. Love it.
Or just eat more fish. But sometimes people don't want to eat fish, don't like fish, or have allergies to fish. Take omega-3s.
Yeah.
Well, that's a preconceived notion that I have and maybe others have, because I thought when you're pregnant, you're told not to eat fish or to stay away from fish, to be honest with you.
Because of
the mercury
poisoning.
Yeah, but there's a study where they gave pregnant women salmon roe, and this was very important for developing the child's brain and IQ.
Oh, that's good to know.
But eat more fish, make people less depressed.
Omega-3s I know are fantastic for mental health, and something I always recommend too.
So this here in blue was all like the nutrients and dietary component, and then down here we're going to get into other things like hormones and certain herbals. So one of the herbals I have on the list is GABA L-theanine. So GABA is a neurotransmitter, and then L-theanine is a green tea extract. And this is very good product I've used from Quicksilver Scientific that we'll link in full script. And like 2 drops on that, it chills someone out. I mean, their anxiety is decreased. They can use it as needed. They feel much more relaxed. Great product.
Wow, L-theanine.
Yeah, green
That's
tea.
okay. Green
Green
tea.
tea.
That makes
Yep.
sense.
Melatonin. So 1 to 2 milligrams at night. And let's be realistic. People are under fluorescent lights. They're working shift work. Their circadian rhythm is disrupted, and you got to pay the bills. It's not like you can quit your job. So you take a little melatonin at night. You're going to sleep better. It's an antioxidant. It decreases so many diseases. We were just at the anti-aging conference in Las Vegas, attended a lecture by Dr. Terry Denoy on melatonin. Oh my God, I didn't even know how many things it works on, but decreases COVID. I was using it in the pandemic to treat COVID. It's an antioxidant. But the simplest, it improves your circadian rhythm. We're exposed to a lot of artificial light, so people's melatonin isn't increasing at night, so they're maybe having a hard time going to sleep. I don't have an issue. Give them a little melatonin, like 1-2 milligrams. It'll help.
Melatonin is an interesting one, and I've heard a lot of pushback on it, and I'm sure we know where it comes from. But one of the things when I'm working with my clients, I hear them get resistant to melatonin for or due to is they are afraid it's going to reduce their body's ability to make melatonin.
Yeah,
And
I've heard of that too, in that the kind of like holistic pushback movement. I think it's unrealistic. I mean, we know that shift workers die more often, they get more cancer. Like, did you know that the ER physician specialty has the highest suicide rate of any physician specialty?
I
And I
believe
think
it.
I think it's because of the disruption of the metabolic. You know, I worked in the ER. I know this doctor I worked with on night shifts. He was 60 years old. He developed diabetes. He actually had a smart primary care, surprisingly. And the primary care told him to quit the night shift. Lo and behold, his diabetes got better. So just by going back on a proper circadian rhythm, getting a little bit more sunlight exposure in his life, his diabetes reversed. So I push back against people who say, "Oh, you don't need hormones. Hormones aren't natural." It's like, hey, listen, you are suffering. I mean, give yourself something back.
Yeah. Well, it's like we hear that they won't take melatonin, but then they'll take, I'm trying to think of that
Caffeine,
like,
coffee all day. How about that?
well, coffee all day, but the ones that help you sleep at night, and I can't think of the names of them.
I
They're
mean,
like on the tip of my tongue.
they'll use these herbals. They'll use like ashwagandha. They'll use rhodiola, magnolia. My issue with that is, yeah, okay, cortisol is high at night, so you can suppress it with these herbals. And yeah, it might not be a bad idea if you've tested and your cortisol is high at night. But what may be more likely is your melatonin isn't high at night, and you have like a normal
Mm.
cortisol, and you're trying to suppress it with herbs. That's why I try to stay away from too many herbs. A lot of people are into the herbs now. They have their time, they have their place. But the first is like the basics, and then the hormones, and then herbs. I mean, you can use a little harmless herb like L-theanine, I mean, it's a little green tea extract, but
No, no, that makes sense. I was thinking of the actual like prescription medications people use to sleep. I can't think of the names of
oh my
some of
God,
them.
there's so many. I mean, in
Mhm.
psychiatry, we were using atypical antidepressants, so these antipsychotics,
Yes.
because they come with these side effects of sedation. So we actually were using the side effect for an intended purpose. So off-label use, you give somebody like, this was olanzapine, the one that makes people fat. You give them that at night, sedates them, puts them right out.
Hmm. Which is such a like conflict of interest, right? They won't let these things because they're not FDA approved, but
Right.
they'll use off-label. Yep.
Oh my
Okay.
God. We were
Fine.
using all the time off-label stuff in psychiatry. Hydroxyzine. So we're using Benadryl. So these H2 blockers at night to sedate people to go to sleep. We would use the atypical antipsychotics for all sorts of off-label purposes besides bipolar depression, like sleep being the big one.
Mhm.
You would use Wellbutrin, although I think Wellbutrin got an indication for smoking cessation. But you would use Wellbutrin off-label for someone with fatigue because it's a bit stimulatory. I could go on and on about the off-label uses of, antidepressant in psychiatry, but I got in trouble for telling people to take vitamins.
Well, that's also where I want to call out the hypocrisy, because so many people are getting stuck on, like, I'm not going to take any of these supplements or anything because they're not FDA approved, but yet we're taking like 5 or 6 multiple medications that may not even be used for the intended purpose that the FDA approved them for. They just happen to be also working for this area or for this problem. And I mean, people are on so many medications, they're becoming walking zombies. Like, I see it all the time. It's unworkable for therapists to even work with at that point.
They are. They're not treated at a root cause approach. And the root cause approach is often hormonal dysfunctions. And that's another thing I got in trouble with in psychiatry is, I have testosterone here on the list because I would order testosterone levels in depressed men, correctly assuming that it may be related to their depression. And I got, called in by my administrators and like, why are you ordering this? I'm like, well, they're depressed. Well, wouldn't the primary care do this? I'm like, the primary care has no clue about hormones. Well, if you really think they have low testosterone, you should send them to an endocrinologist. Like, you want me to send them to an endocrinologist to manage this? I mean, I guess I could, but why don't I just do it? So I don't know, that you just get set on this like specialist wheel of pain because there's this weird idea or this dogma in medicine is you don't want to step on someone else's shoes. So if you're in psychiatry, you just do the SSRI. If you think they have a testosterone deficiency, you send them to the endocrinologist or the urologist, as if it's not one human body and everybody has to go to different specialists for things. This is a waste of time, in my opinion.
Right, and it's known that each time you have to go to a new specialist, that you have to start all over with that new specialist, and sometimes they don't even know what you're talking about.
And the problem is the specialists, they have like 1 year wait lists. I mean, they're so busy because they're getting stupid referrals all the time because a primary care can't do their job, doesn't have time to do their job. And then every other specialty thinks it's somebody else's problem. So you just craziness. And no wonder there's a 9-month wait list and you have an actual problem that needs to see an endocrinologist.
Right, and another one that comes to mind is a rheumatologist. I know, especially here in Utah, they're like a 1.5 year wait list right now.
Yep. Everybody has chronic pain. And a lot of this stuff can treat chronic pain. I mean, testosterone, you give guys back testosterone, their joints hurt less. You give it to women, they can lift weights and they could recover again. They're not in pain for a week. And that turns a lot of people off of weightlifting is because of poor recovery. That's hormonal dysfunction. You need hormone replacement. You're past age 50, you don't produce the same hormones, and you're going to expect to go to the gym, work out like you were 20 and not have pain. It's unrealistic.
Right, and on the topic of referrals, I just want to put this one out here because I'm always asked for psychiatric referrals or psychiatrist referrals. And in Utah, it's at least a 9 to 10 month waiting list. And if you're dealing with problems, that's a long freaking time to be waiting to see a psychiatrist for medication. And I want you to take this list seriously because these are things that you can do for yourself that will help. And depending on that, maybe you won't need the psychiatrist. I don't know.
Yeah. I mean, we do everything here at Iron TPC. We're a primary care that's how primary care should be, where you actually manage everything and you rarely refer stuff out. I mean, I'll prescribe, an antidepressant if it's indicated. I can't think of the last time I did because there's so many other options I have. That's the thing about functional medicine is I always have something else in my pocket. I got peptides. I've got, all these things that, can help. So I rarely use a psychiatric drug. Let's see what else we have on this list. DHEA and pregnenolone. So these two are neurosteroids. I'll use them for post-concussion syndrome, sometimes along with phosphatidylserine, because they help, they protect the brain, especially pregnenolone. And they're also cortisol support. They support your cortisol production. A lot of people are under a lot of stress, chronic illness. They maybe have an inflammatory disorder. This actually uses up your cortisol. And so people oftentimes have low cortisol, contrary to popular belief, where everyone thinks they have high cortisol and need to take ashwagandha, right? Low cortisol is a terrible condition because these people are fatigued. They cannot move. They have no energy. They have high inflammation. Everything hurts because they don't have cortisol production that can put out the fire. And that's a lot of the case with people with food allergies and gut problems. All their cortisol is used up because their gut is constantly inflamed and they're constantly stressed and they can't sleep. So you give them a little precursor support, it can help them sometimes. But besides that, they support all other downstream hormones. They're neuroprotective. They improve your testosterone production. They improve your bone density, your muscle mass. And then DHEA also improves the oil on your skin. We have a problem with it when we're teenagers. We may get acne from too much DHEA production. That was the bane of my existence at age 16. It was not pretty. You would not have liked to know me then. But now at age 32, I don't have much oil on my skin. My DHEA is actually low, and I'm replacing it. So I replace my DHEA. I take about 15 milligrams a day, and it improves the oil on my skin now.
Wow. And I'm sure that helps with like elasticity and wrinkles, it sounds like.
Correct. And it improves
Okay.
testosterone production. It
Hmm.
improves mood. People like it. You know, it's actually, I was at a functional medicine conference in Rome, Italy last month, and I learned these are actually banned. You can't prescribe them unless you're an endocrinologist in Italy.
That's sad.
Here
That's
they're
such a
over the
sad.
yeah, they're over the counter in the US. They're actually over the counter in Europe, so you can still get them over the counter in Europe, but you can't prescribe a lot of these things because they're considered anabolic steroids. Crazy, right?
I just want to back you up for a second. It looks like we skipped over one. IR/NIR.
Oh yeah, that's light therapy. So there's a
Ooh.
lot of good studies coming out about infrared and near infrared light therapy improving mood, depression, collagen synthesis on the skin, chronic pain. And we have this amazing case here at our facility where this lady, she had trigeminal neuralgia, which is a very painful condition of the nerves in the face. And I mean, she was at her wit's end for this, and this was causing her to have, bit of, depression, suicidal ideation. And we put her in front of the red light, and she did this over the course of a couple weeks, along with a little bit of physical therapy. With the pain, 99% resolved.
Wow.
Pretty powerful.
That is powerful.
Yeah. There's good companies. We like BioLite. He's actually the owner got us into the conference in Rome. So really cool. Mark Bukowski. He's done a lot of research, done a lot of third-party testing on the BioLite, and like more N nanometers isn't necessarily better. There's a certain wavelength, about 680 nm, that gives you a good amount of deep tissue penetration and superficial for your skin health. And then you also get the pattern of light that's the red light. It's very good for our eyes and our brain. It makes us feel good emotionally. So two patterns of light, two wavelengths, and we'll put a link in the description for BioLite to Mark Wilkowski's site because he's a good guy.
Absolutely.
And then we have E2, which is estrogen. So this is very important for men
Okay.
and women. Women postmenopausally don't produce estradiol. They may produce estrone peripherally in their fat tissue. If they have a lot of fat tissue, this can actually be a little bit of a problem, and they get estrogen proliferative disorders. This is where they can get cysts in their breasts, they can get breast masses, they can get ovarian growth, they can get endometrial overgrowth. So a problem for women, and then also a problem for men if they have too much estrone production. Their prostate can grow, they can get nipple sensitivity, they can also get breast tissue enlargement and also breast cancers. But estradiol E2 is very important for emotional health, cardiovascular health, chronic pain, collagen synthesis. Women need estradiol, and it should be standard of care to replace estradiol postmenopausally and even perimenopausally so that women never have to go through hot flashes, depression, vaginal dryness, lack of sexual interest. This can all be prevented. Oh, I had another lady the other week, and I reversed her urinary incontinence. She couldn't ride her horses because she was having urinary incontinence.
Wow.
I gave her hormone replacement intravaginal. I mean, she can ride her horses again. She says it's the best thing ever. I had this other lady. She was 62, and she had written off having a boyfriend. She was like, well, that's it. Written it off. Got her on hormones, testosterone. She's like, wow, I'm interested in men again. I mean, she got a boyfriend. She was super happy. And then her boyfriend dumped her. And she was like, oh, I actually stopped the hormones because I had all these urges and I had no one to help me with them. I was like, well, they're good
Oh
for
my.
yeah, I was like, well, we do the hormones for other reasons besides the sexual. We do it for the bone density purposes, the skin elasticity, the brain health. We can prevent a lot of neurodegenerative conditions, so Alzheimer's, dementia, with proper hormone replacement. This is now we're studying this, we're seeing this, cardiovascular disease, metabolic dysfunction, oxidative stress, inflammation, autoimmune. With proper hormone replacement across the board, you can improve these things. But emotional is probably one of the most powerful with the hormones.
I don't want to take us too far off topic, but one I just want to even bring awareness to that's very, very common. And so are the side effects when it comes to the mental health side of them. And that's birth control, right? Like that's all hormonal. And women, I've dealt with it too. The biggest side effect that I've seen and people that have complained about is I went extremely suicidal when I started birth control. And that's really scary.
Terrible. Yeah. So now we know that the birth controls, they increase risk of uh, decrease in bone density, increased risks
Yeah.
of depression, anxiety, cardiovascular disease, blood clots, and so on and so forth. I don't think anybody should be using birth control. There's natural planning methods. So if you go to your GYN who prescribed you a birth control, ask them to run your hormone labs. They won't. They do this. If there's actually been never any published study of what happens to the female hormones on synthetic birth controls. Look it up. You cannot find a study. I've looked. If you find one, send it to me. I'd like to see it. And at our practice, and maybe I should publish studies on this, we are seeing what happens when you put a female on synthetic birth controls. What happens is they get postmenopausal levels of estrogen, postmenopausal levels of progesterone, and very low testosterone, oftentimes absent DHEA, very low pregnenolone. So what it does is it seems to shut off their hormone production. It put them in this perimenopausal, postmenopausal state while giving them a synthetic hormone that I cannot measure in any standardized lab testing. If you're taking a medroxyprogesterone or a progestin, I should say, not a progesterone, progestin or an ethinyl estradiol, I do not have a laboratory I know of that can measure this. So you're getting a synthetic, immeasurable hormone. You're suppressing all your natural hormones, and you're doing this for years.
Wow.
Crazy.
Didn't know that. Yeah,
Yeah.
I get it. When gosh, I feel like our generation, we were on it starting in teenage years, and a lot of people are starting to come off of it, which is great.
Yeah. And I recently got a lady off of it, and she's doing well. She's age 31, and her hormones came back. It was so cool. We saw progesterone like undetectable, estradiol like less than 30. We had a DHEA of 90, and her estradiol came back. It's now 160. Her progesterone is about 8.6. This is obviously measured during peak luteal phase, so between day 19 and 22. That's when you can measure the estradiol to progesterone ratio. Her DHEA went from 90, which is an 80-year-old's level. It went up to 140, which isn't optimal, but it's coming back. So the hormones aren't optimal, probably from birth control use, but they have come back, which doesn't always happen for some women.
Yeah, that is awesome. Wow.
Yeah. The other one we mentioned is progesterone. So progesterone we replace, and this isn't medroxyprogesterone. This is bioidentical progesterone. It's not a progestin. So we replace this in women postmenopausally, perimenopausally, and unfortunately even younger, because for some reason, a lot of women are not cycling their progesterone anymore. And this can appear as prolonged menstrual bleeding, menstrual cramps, fibrocystic breasts, where they get like a high estrogen compared to progesterone. They get overgrowth of the endometrium. Again, this is high estrone, low progesterone. Progesterone helps women sleep. It improves their mood, decreases their anxiety, right? So you can give progesterone orally to a woman, and it gives them a sedating effect. They sleep again. It's amazing. We've done this for so many women postmenopausally who haven't slept in 10, 15 years. You give them back sometimes they're even sedating themselves with alcohol. They're using whiskey to go to sleep, or they're on, those psych drugs that we talked about to sedate them. You give them a little progesterone, it has a nice sedating effect, gets them to sleep. You can do it transdermally as well. Transdermally has less of a liver conversion to allopregnenolone, so maybe a little less sedating effect. But you get all the benefits of progesterone. You get the balance of the estrone, the cognitive benefits, the neuroprotective benefits, decreased risk of Alzheimer's. So a lot of benefits to progesterone.
So interesting how many different things play into others.
Right. And then here, number 13, we have IGF-1, which you can measure in the blood. This is a proxy marker of growth hormone. The growth hormone is also well established. Dr. Terry Hertog will tell you the studies, how it decreases anxiety, helps with mood, helps with tissue repair, collagen synthesis, makes you able to train and recover. You want to try to increase your IGF-1. You may need to get it replaced. You may need to have growth hormone replaced if you have very low growth hormone. adult growth hormone deficiency is a real thing. You can diagnose it. It's a little bit tricky, but that's something to look at as well if the mood isn't getting better. And there's growth hormone analogs you can use. You can use some peptides. There's some deer velvet antler extract, like the bioprotein. We use that sometimes. We've had very good results with that for improving people's well-being and health and mood.
Wow.
Yeah, growth hormone.
And then I see coming up next is cortisol, which is one that I really want to talk about.
Yeah, so in some patients, you can measure it with a salivary hormone, which is really the only way to properly measure cortisol. It's a 4-point cortisol test. You check the saliva throughout the day. And cortisol should actually be high in the morning and then kind of go down by noon. And then in the evening, it's very low. But there's some patients with chronic fatigue and autoimmune conditions and a lot of inflammation. They've burned through their cortisol from years of stress. And so they actually won't have cortisol go up in the morning. And these people will be chronically fatigued. They'll have pain. You can give them a little cortisol, Cortef in the morning, physiologic replacement dose. We're not talking about prednisone, which is, 20 times maybe higher, more potency. We're not talking about these dexamethasone, these synthetic cortisones. We're talking about hydrocortisone, Cortef. 5 to 20 milligrams is a physiologic replacement dose of cortisol, and you can give it to chronically fatigued patients when other things aren't working, when the cortisol is low and you're not able to get it up naturally with sunlight exposure, grounding, etc. I know, maybe quitting your job if it's stressful and so forth.
Not working night shifts. There you go.
Not working night shifts. I mean, sometimes impossible for some. I mean, if you're working night shift, I would prescribe melatonin at night and a cortisol in the morning if, you have to go about your day and be with your family. I know I did that when I worked night shift, and that was tough. Sometimes converting myself off the night to the days so I could have some level of social life.
Well, and I don't think we even take into account how much social life plays into mental health. Like if you're working nights, sleeping during the day, social life is hard and you're missing out, and that's also depressing.
And then 15, last but not least, is the thyroid. We mentioned that here with the iodine and selenium and B vitamins, but you can replace thyroid as well. We do it all the time. A lot of people will get levothyroxine or T4, which now they're coming out and saying that it increases risk of bone fractures, osteoporosis. Not sure why that might be. That's just now what's shown. I replace T4 and T3. So we do desiccated porcine thyroid, so NP thyroid, Armour thyroid. And this is a prescription pharmaceutical drug, but it's from dried pork thyroid. And then you could take it, think of it like an organ meat, and it gives you both T4 and T3. And then why both, right? A lot of people are on T4 and some people are fine. But at least 40% of the population, they won't convert T4 to T3. And T3 is the active thyroid hormone that gives people energy. And it helps them feel good. It helps your joint pain, helps their mood, helps their brain. So T3 is what you need. Now, if you have enough IGF-1 growth hormone, you'll convert more T4 to T3. If you don't have super high cortisol, which will, if you're chronically stressed, your reverse T3 will increase, which is something you can measure in the lab work. If reverse T3 is very high, you do not convert as much T4 to T3. So you'll never get the benefit of the levothyroxine. It will never really work. And unfortunately, a lot of people aren't getting the real test. You're not getting a free T3, free T4, reverse T3, TSH, thyroid peroxidase, and thyroglobulin antibody. They're just getting a TSH. You should never dose a thyroid medicine off the TSH. The TSH is just a signal. And if you're trying to dose a medicine off a TSH, it's like trying to look into a room through a keyhole. You only see like a little part of the room. You don't see everything else. You never understand why a patient is fatigued because their T4 is not converting to T3. So I just take it a step further. I just give people T4, T3. They feel great. You don't mess around with the levothyroxine. I mean, there's a certain segment of that, like, oh, I like levothyroxine. All right, fine, great, good for you. It doesn't work for a lot of other people. Get the proper labs done.
So my main question is, if people do want these labs run, can they go to their primary care doctor, or do they have to go to a functional medicine doctor to get these specific ones done?
No, you're going to get a panel of blood work that costs approximately $9.50 that your insurance will cover. And this includes this includes a CBC. This is like $2.30. A CMP, which is like $1.40. You'll get a TSH, $1.20, and a lipid panel, which is like $3.20 because everyone wants to lower your cholesterol, which you need cholesterol. I forgot to mention cholesterol is critical to produce all these hormones. It's the first molecule that converts into pregnenolone, then pregnenolone converts to all these other hormones we talked about. You need cholesterol. So, but they want to lower your cholesterol because you have to get a certain amount of patients on a statin drug to make sure you get reimbursed by insurance companies so you can make the paycheck and keep the lights on. So that being said, you're not going to get real lab work done because the other reason is the reason these labs are covered is because you can get a general ICD-10 code. So this is a diagnostic code for a well exam. And those labs will be covered. If you want to get your testosterone measured, you have to be diagnosed with hypogonadism in a male or female hormone replacement therapy. So you have to put this ICD-10 code on the order when you submit it to Quest or LabCorp or whatever. And only then will the lab recognize it as a valid code for a valid indication, be able to submit it to insurance companies. If you submit testosterone to the insurance company without the appropriate code, you'll actually the first of all, the insurance won't pay for it. Then the lab will want money, and so they'll send you a bill in the mail. And a testosterone, not at a wholesale price, costs about $600. But if you get it direct from a direct primary care like us, we have pre-negotiated rates with labs. I can get a testosterone free and total for $17 instead.
That's really incredible information to have. And another thing I want to bring up too, and maybe you can explain this a little bit more, is that a lot of people will go to their primary cares and ask for specific labs to be run, and their primary care won't do it because they say that the insurance isn't covering it.
And the other reason is because then they're going to be stuck with it. And if you order an IGF-1 level, and your primary care hasn't gone to functional medicine conferences, hasn't spent the time studying what IGF-1 is outside of like Turner syndrome in short stature children, they won't know what it means. They won't know what to do. And the problem with not knowing the results puts you on the hook liability wise. So say you have a very high IGF-1, it's 420, and you ordered the test because the patient asked you for it. You didn't know what it meant when it was that high. You didn't know that that could potentially be a pituitary adenoma, a brain cancer. And so you let it ride. The patient then gets a brain cancer, dies, and then sues you. So you have to understand it from the provider's perspective too. They're not going to order labs they don't understand, aren't familiar with, because that could lead to a bad result for them.
I really like to see it too from the perspective of it's okay to shop around for a doctor that knows what you need and maybe can answer the questions that you have. I don't think it's a bad thing if you're feeling like unsupported by one doctor to shop around. I'm a huge proponent of it. That's what I did, and honestly, I couldn't have been happier that I didn't settle for a doctor. One other question that comes to mind, is this full script prescription, is that something everybody can access once they have the link in our description?
We should put it in the show notes so people can order some of these things. And the BioLite, and then I'm keeping we can also put the page. I have a website page now that's keeping a list of all providers that think like me across the US. I don't have Utah yet, but I have a decent amount of other states covered with friends of mine that we were just hanging out with them at the anti-aging conference in Las Vegas. A couple of great thinkers, hormone experts. So we have a couple other states covered.
I think that is a great resource to have because I know people listening aren't just from Utah. They aren't just from Florida. Yet I am still looking for somebody from Utah. I'd love to meet somebody that's like-minded in Utah. Maybe you're listening. Maybe you can reach out. But this list is great to have.
Maybe. Very good. I think we covered a lot today.
I really appreciate you taking the time to talk to us today. Where can they find more about this information you've described in your practice?
They can follow me and learn more about these subjects. I have a YouTube channel called Iron Direct Primary Care. The same on Rumble, where I'll post some more controversial stuff that gets censored. Same Instagram, Iron Direct Primary Care. And then X, Twitter is Iron DPC. You can find me there. I post a lot of educational topics and give a lot of talks.
I'll have those all down in the show notes. Thanks for sharing this with us today.
Good chatting.